Hello, everyone. My name is Mark Jeans. I'm a psychiatrist working at Alfred Health in Melbourne. Before I commence my talk, I would like to say thank you to the organising committee for the invitation to discuss some of my work as a liaison psychiatrist with the HIV service at Alfred Health, with particular reference to the COVID pandemic. As a point of orientation, Alfred Health is a tertiary health network based in Melbourne, Australia. The HIV service I work with offers multidisciplinary healthcare for people living with HIV across the state of Victoria. I also wish to acknowledge the traditional custodians of the land on which I have prepared this presentation, the Dja Dja Wurrung people. I recognise their continued connection to the land and waters of this beautiful place. I respect all Dja Dja Wurrung elders and ancestors and any First Nations people participating today. I have prepared these slides from this beautiful setting, not just for their lovely filtered light. I wanted to highlight some of the changes in our practice that have been accelerated as a consequence of the current pandemic over the last 2 years. You may be familiar with the concept of a therapeutic frame, which refers to the setting of engagement in psychological care and the impact this has on participation. There are some very traditional aspects of this theory, but at its core, the purpose of constructing such a space was to facilitate a trusting environment, specifically separated from the outside world, to encourage spontaneous expression. Also important was the establishment of limits to the interaction as an avenue to the exploration of therapeutically raised frustrations and deprivations. The frame includes the physical environment, but also the ground rules of the interaction. You may recognise the attached picture as Freud's consulting room. And to reference this, you might consider that in the past 2 years, the Persian rug has been pulled from under our feet, in that the physical space has been dissolved, and so the ground rules of interaction have been redefined. Of course, the original frame model has been evolving, and back in 1993, Winiarski wrote about bending the frame. And this has been especially evident in mental health care for people living with HIV, whose needs have always benefited from a flexible approach to mental health care. This has been reflected in many discussions in my work around role definitions and flexibility in interactions to resolve issues like delivering information outside a clinician's scope of their discipline, managing contact between scheduled appointments, and implications of modes of contact other than face-to-face interactions. Certainly, the vastness of Australia has always necessitated the use of distance-based interactions, but this has been an exception in urban settings until the impact of the COVID pandemic. 2 years into this now, it feels second nature to be able to conduct a telephone or video-based assessment. The development of communication technology that would have been considered science fiction a generation ago, and its widespread distribution in the community, together with the advanced state of medical science and almost the expectation of vaccine development by the general community, have facilitated lockdowns being broadly tolerable. And that is explained by people who are willing to make sacrifice towards a greater goal and for widespread changes to remote healthcare delivery were able to be accepted quickly into practice. But it is worth considering the potential costs in the light of the theory around the therapeutic frame of these changes. I have had more than one already isolated person with diagnoses ranging from extreme anxiety to prominent negative syndrome schizophrenia suggest that they would be content to continue phone consultations forever moving forward. And I'm unsure if the benefits of this will continue once the infection transmission risks resolve. I've also had instances where I've contacted a person at the appointment time to hear street noise in the background or for them to describe the shopping they are doing. And although this has not been an issue for the client, I found it more difficult to find the clinical focus, and I was perhaps more reticent to ask more difficult questions without the reassuring structures of the frame around me. I also have reflected on the quality of the interaction, for although the data of the assessment is quite readily communicated, I have found that emotional tone is not so easy to communicate, and this is bi-directional. on one side of the screen, I find myself feeling a little like I'm acting in a pantomime in order to make sure my expressions can be read on the other side. And similarly, me trying to interpret humour or sarcasm or distress from the other side of the video screen is much more difficult without the subliminal cues of body language and the environmental milieu. In my experience, clients have not only accommodated this change, but are often appreciative of the opportunity as a way to minimise their exposure risk. And I think that the efforts being made to be flexible and accommodating are seen as an extension of care that overcomes the physical distance and provides a solid basis for establishment of rapport. It's important outside the consulting space to consider fair access to services maintained for people who have limited financial means, or who live in rural settings where coverage is reduced, or who have been unfamiliar with technology or have cognitive impairments that make the use of technology more difficult. And I've noticed that in addition to provision of material support such as housing and sustenance, providing a mobile phone or other means of communication has become a routine part of discharge planning and an important consideration when we are at the end of the patient's inpatient admission. Like many people, judging by the book sales, I ordered a copy of The Plague by Albert in the early stages of the pandemic. And although this is a multi-layered work with a variety of interpretations, the author, in his preparations, researched extensively the impact of historic plague episodes, such that the story mirrored in a disconcertingly prescient way the early phases of the pandemic for me. Although I found it a confronting read, it had a strange calming impact because, in contrast to the news reports when I felt a bit overwhelmed, I could put down the book for a while. Although for the majority of the population in the Western world, the COVID pandemic was the first public health emergency in living memory, and it felt catastrophic, this was not the case for a substantial number of people. There are obviously communities living with the memory of MERS and SARS and Ebola outbreaks, and of course those living with HIV had an especially relevant lived experience and may not have been as startled by the events that unfolded. The types of things include specific recapitulations of the experience of having an illness at a time of emerging scientific knowledge. And while the vast majority of people living with HIV and AIDS were able to transfer a trusting relationship with service providers, there were people with higher levels of anxiety or a more distrustful pattern of relating who were reminded, for example, of the emergence of various side effects of early antiviral medication, and in this state of mind were more vulnerable to the rapid spread of news about adverse effects of vaccines. And because of this, were more than usually tentative in their decision-making. There has also been a rapid increase in the public knowledge of theories around public health and familiarity with vocabulary around transmission rates, virus mutations and virus resistance, etc., in the public domain. And clearly, education has been vital to foster an informed public health response. The importance of the interaction between political leadership, scientific knowledge, and civic responsibility has been a topic of social media, and in the past would have been discussed around dinner tables or the water cooler. And these communications have appealed to a rational and considered response to this public health emergency. This has been important in order to implement social change on a vast scale. But unfortunately, one of the instinctive responses to creating social change by affecting group dynamics is to create a protected group, and by definition, an other or an outsider group. as this reinforces the feelings of cohesion and anxiety, reinforces the feelings of cohesion and safety for those on the inside. In this setting, it has been a common experience in public health for people to become stigmatised on the basis of their health status. And recent reported comments from the French Prime President reveal how delicate this balance is. He's been quoted as saying it is a deliberate strategy to antagonise, and his language was more coarsely translated, to antagonise people by restricting their access to social activities, so much so that they prioritise vaccination. That is, using social control in the perceived common good. And of course, there were recollections of social exclusion for the people living with HIV and AIDS. Although this possibly was not quite as pointed as the volatile mix of segregation based on the moral overtones associated with sexual behaviour and substance use. There were, however, rapid redefinitions of appropriate behaviour, and things like invasion of personal space was associated often with raised eyebrows from people who felt intruded upon. I think it is worth reflecting on the legacy of Gaëtan Dugas, whose infection with HIV led to the type of demonisation seen in the headline on this slide from 1987. This was the final outcome of a process that occurred by misinterpretation by sensationalist media of the investigative reporting of scientific data. And it gained traction as it satisfied the need for a scapegoat and appeared to offer an easy solution to a very large problem. In fact, it was the cooperation of Mr. Dugas, his open and detailed account of his behaviour, and his commitment to be included in research that allowed for important epidemiological knowledge to be developed. And this was not widely acknowledged until many years later. Without recounting specific examples, there were very clear instances of this type of scapegoating associated with COVID that warranted strong social responses. And I think in the role of clinicians, it is worth considering that this may also be a part of the personal experience of those that are unwell, and for us to be sensitive to the effects of this on mood and self-esteem. It is also relevant to listen to the resilience that has developed in people who have had this experience. There are not homogenous results in the literature yet, but when we try to quantify the impact of COVID on anxiety levels in the population, there is one observation that people with pre-existing anxiety disorders have not actually been made worse. It has been the people without pre-existing anxiety who have been more vulnerable to increased anxiety levels. We may have something to learn from this, from the hard-won expertise of those who have previously found ways to cope with the idea that the world is not always an entirely safe place. And there are many examples, one of which is the Dulwich Centre at Melbourne University, where people with lived experience have made publicly accessible video content that describes their strategies for coping. And these are worth reviewing and including in our repertoire of strategies for coping. I'd like finally to talk a little bit about the impact of the pandemic on clinicians and first-line responders. And to return to Freud's consulting room, it's worth noting that this was part of his home in Vienna, and his family descriptions are of him coming to lunch daily between his consulting sessions. And so the home office innovations that we have been embracing would have been entirely familiar to him a century ago. And to re-involve Camus and his characters from the plague, the main protagonist is a local doctor in a specifically described ordinary town who opines that the only way of fighting a plague is with what he terms common decency. And when he's asked what this means for him, he responds by saying tentatively, I know that because he doesn't really know the answer, but he says, I know that it consists of doing my job. And he was responding in part to the idealisation of frontline responders to the plague as heroes. In the book, it needs to be taken in the context of the time when doctors were seen as paternal, selfless, authoritarian, and sources of expert information that was rarely challenged. And this has clearly evolved. Undoubtedly, today's healthcare workers and other essential workers deserve every accolade for their hard work, but the pressure of living up to heroic expectations may have lasting impacts on the sustainability of that work. To rely on concepts of altruism and devotion to duty can make it difficult for staff to acknowledge and to communicate the limits of their coping. The demands of the workplace have included a need to accept sudden changes in responsibilities, incorporation of new ways to communicate, processing of fluid information, and the management of distressed patients and carers who are often even more challenged by the dynamic nature of the health system. This is in addition to the personal concerns regarding contagion and transmission within their own personal networks. In Victoria, reputedly with the longest lockdowns in the world, the surges in health demand have thus far been able to be reasonably managed, and I recognise that this has not been the case in other parts of the world, where people have been unable to access healthcare, leaving staff possibly with conflicted feelings arising from working diligently in a system that may have been perceived to have failed. And this is a significant threat to the ongoing viability of the workforce and needs specific attention. I spoke earlier about the access for our clients to technology, but it's also important to acknowledge that we are also on a steep learning curve in the application of clinical skills in the information technology age. And so the availability of up-to-date functioning equipment and the expert advice on how to get the most out of it is an important consideration. And also there may be an opportunity with this skill development as a counterpoint to the so-called fake news of social media to encourage and facilitate skilled professionals to capture the audience with accessible messaging. And lastly, just some strategies that have been considered to help maintain staff morale have included programs such as offering specific individual counselling, but this is often found to have limited uptake. And there are always challenges in trying to put time aside in an already overloaded schedule for these types of programs. And there's often a balance to be struck between providing this in an encouraging way rather than something that's considered to be coercive. Also, that there is a challenge to make it, connected in some way to work, but also distant enough that people feel free to speak truthfully and honestly about their experience. I also noted that physical space has been an important part of stress management, and there are organisations have partitioned dedicated staff spaces. Where I work, the area that was previously the cafeteria and outdoor dining space, which had grass and a few trees, was reallocated as a dedicated staff space to allow people to decompress. And that seems to be a very widely used space. And I think finally, it is important to acknowledge that financial payments as a tangible recognition of the increased demands of the current environment are a very valuable incentive and reward for the services. I would like to end my slide there and thank you for your time to reflect on the intersection between HIV care, COVID and mental health. I wish you an enjoyable experience with the rest of the conference.